My name is Dr. Jonathan Kim, and it was a real honor to lead this with two of my closest friends and colleagues who are with me here today, Dr. Aaron Baggish and Dr. Ben Levine. To begin with, we have to talk about some historical perspectives. And the perfect person to begin this discussion would be Dr. Levine to take us back through the Bethesda Conference proceedings. Ben.
Thanks, Jonathan. Well, the Bethesda Conferences were started back in the mid-60s, and they involved getting a group of experts together for 2 or 3 days in Bethesda at the Heart House to provide guidance to the cardiovascular community. And the 16th Bethesda Conference, which occurred in 1984, was focused on the management of athletes with cardiovascular disease. They invited experts from all around the country to get together to talk about not just hypertrophic cardiomyopathy, but to provide a broader perspective on management of athletes with heart disease. Those Bethesda conferences were repeated just about every 10 years. There was the 26th in 1994. That was the first one that I participated in. The 36th was done in 2004, and then the next one occurred in 2015. And I think that's when Aaron really started to get more intensively involved in the process. And so I'm going to turn it over to him to sort of bring us up into that modern era.
Thanks, Ben. That history is incredible in terms of setting the stage for this discussion. I think if we pick up with the 2015 guideline, it's important to recognize that it was still named a disqualification or a sports determination document. You and I were both on that paper, not in a leadership role per se, but playing a role in the writing, was really again geared toward figuring out who to disqualify and who to permit to play sports. So a couple things that were pointed out in the 2015 document. First is that all of the recommendations were regarded as generally conservative. And it was put forth at that point that a conservative posture is prudent when there's limited available evidence. Basically, that if the data are not concrete to help a doctor make a decision for a patient, that it's best to be conservative. Now, let's be clear. In the last 10 years, the field of cardiovascular medicine, the field of general medicine for that matter, has evolved away from thinking about those areas of uncertainty in which either conservative or paternalistic care is the best approach, to acknowledging that when we don't have the data to be clear about the right decision, that's really where the patient's voice and the patient's involvement in their own trajectory becomes really important. And that's really where the term shared decision making is now the foundation of the new document is so important. I do want to point out that shared decision making in the sports cardiology world is not new. Certainly it's gotten a lot of traction over the last 10 years, but even in 2015 with the last iteration of the Bethesda Conference proceedings, which for the first time then was a shared ACC-AHA document, there was still not a single mention of shared decision making.